Professor Paul Smith AM is one of Australia's most experienced and highly regarded hip and knee surgeons. He is a Professor of Orthopaedic Surgery at the Australian National University, Director of the Trauma and Orthopaedic Research Unit at Canberra Hospital and the John Curtin School of Medical Research, an Orthopaedic Unit Director at Canberra Hospital. Professor Smith is Chair of the Australian Orthopaedic Association, ACT branch, and the immediate past Chair of the Royal Australian College of Surgeons, ACT branch. He's passionate about research and training, and as both these lead to improvements in equipment and techniques, which translates to better outcomes for his patients. Professor Smith's main areas of clinical interest include hip and knee replacement surgery, knee reconstruction, joint preservation surgery of the hip and knee, and complex revision joint replacement surgery. Please everyone welcome Professor Smith.
Yeah, just that one. Or is that your presentation? That one.
Sorry, Laura, we're aiming to try and get this to do exactly what we're after.
Oh, that's perfect. Your slides are up now, Professor.
Slideshow.
And we'll just see if we can get it going there. And can you tell me whether or not?
We can just see the speaker's view. So the presenter's view. So perhaps change it to...
That's fine. I will just go to slideshow. Is that better?
That's perfect.
Happy day. Thank you very much for your tolerance. And thanks to the organisers for the invitation to speak, and thank you for your very kind introduction. And I'd like to thank Stephen Halcrow for his excellent insights there. I too remember when CT scans came out in the 80s. When I trained in Adelaide, the currency to get a CT scan on a patient was a bottle of wine to the CT technician. He has an excellent cellar still. So my talk is about improving surgical outcomes and the role of big data in doing so. In giving this talk, I'd like to just disclose my personal involvement with the Australian National Joint Replacement Registry, which I've been involved with since its inception, and in fact before its inception. And sadly, I'm still on the board of management, and I chair the editorial review committee of the registry. And sadly, I can't do the great Oscar Wilde moment and disclose nothing but genius. Fail. Right, big data. Okay, what goes in, what comes out? This talk is all about how we try and influence surgeon results and improve them using our big data. It's all dependent about what goes in. Just a bit of background, the Australian National Joint Replacement Registry is a fully owned entity by the Australian Orthopaedic Association. It's been going 20 years plus now. We started collecting data in '99 with full national coverage in 2002. It's funded on a cost recovery basis through federal government legislation, with the cost rebounding onto the industry. It's a listed federal quality assurance activity by ministerial decree, and that's been tested in the High Court. It has had a major impact in terms of its influence on joint replacement surgery in this country and around the world, and has been recognised for its contribution. It's rather unique. The participation is entirely voluntary. However, we have virtually 100% participation. All hospitals in Australia participate, and all surgeons in Australia, all orthopaedic surgeons in Australia are participating. We've only had 47 out of over 1.3 million patients in the registry who have opted off, and I've only had one. It's really quite surprising. And currently we have information in the registry now of over 1.5 million procedures, and it grows rapidly. So why have a joint replacement registry? Well, it's really because it's such a common procedure. I love this. Total hip replacement was awarded the accolade of the operation of the century by the Lancet in 2007. And I think nothing's come quite close yet. So we're still bragging rights. It's huge business. The healthcare cost is in the billions for joint replacement surgery. And so it's really important that you have a mechanism for quality improvement. Not only do we do more, but the rate of increase is rising. The rate of increase has been impressive over the last 20 years. It's not quite rising as fast as it was in the last 10 years, but it's all about the baby boomer bubble, and I think it'll keep going up. So it's a good thing to do. Okay, what is a registry? Well, in essence, it's just a quality assurance program scaled up. You have to have it properly designed and governed and have a really effective management program aiming to significantly improve outcomes from both the surgeon and patient point of view. Basically, we aim to identify issues of practice and reduce outcome variation to improve care, and thereby reduce cost and increase value in the healthcare system. And indeed, the Australian Council for Safety and Quality in Healthcare have reported enormous cost savings as a result of using a registry and joint replacement. So it's a virtuous cycle, like a washing machine. Data goes in, you have actionable feedback provided to all of the clinicians and other stakeholders, modification of behaviour which is measured, the metrics change over time, and it all goes around again. So like all surgeries, many factors influence the outcome of joint replacement surgery. You've got the patient, the surgeon, techniques used, situations of hospitals and prosthesis-specific factors, and you jumble them all together. The good thing about big data and registries, because you've got such enormous power, you're able to assess the relative importance of each of these factors, and thereby provide insight as to outcome variation. It identifies the best practice and the worst practice, and we can act on that. So when we set this up, we wanted to set up a very accurate and validatable, accurate core minimal data set, and that's the backbone of the registry. That's the stuff we do day to day, but the registry data sets have expanded and have been enriched by linkage with the Australian Institute of Health and Welfare and Medicare data. More recently, we've automated patient reported outcome measures and nested clinical trials within the registry. And so the process continues. We provide enormous variety of stakeholder feedback. So there's a very large annual report, which takes up many weeks of hard work to put together. Importantly, there's real-time website access to the data for surgeons, industry, government and regulators. All surgeons get their individual report annually, and we provide ad hoc reports for various reasons to surgeons, hospitals, researchers and others. Industry use our data for regulatory purposes, and that's recognised globally, and we publish quite a lot of data. Importantly, we participate in government to provide guidance regarding policy change. So it tells you what works and what does not. And one of my favourite science characters is this chap, Jacob Bronowski, who wrote The Ascent of Man. It's a great book. And he was a mathematician, and his wise words were, "Science is the acceptance of what works and the rejection of what doesn't, and you have to have the courage to act on it." Okay, so just some examples. Some in the audience may remember controversy about particular types of hip replacements which involve metal-on-metal bearings. On the picture in front of you, you can see a more conventional hip replacement on the top with metal on plastic articulation. And you can see below that a large diameter metal on metal device. Unfortunately, we identified that this particular device had a much higher than expected revision rate. And the pink line is that particular device, and the blue line is all other replacements. And you can see it's really charting its own course in terms of revision risk. We identified that, and over time, you can see what's happened to this device, that by about 15 years since primary procedure, over 50% of them have needed revision surgery. And again, such an enormous contrast to other joint replacements. So what happened? As a result of the Australian Registry raising the alarm, the device was subsequently recalled. I might add, only recalled under protest. And as a result of that alert from the Australian Registry, the use of metal-on-metal devices has plummeted in our society. Not only large diameter, but smaller diameter devices as well. So it's had a profound influence on practice there. So, harking back to the individual rather than the device, the registry also identifies techniques and prosthesis types that are most suitable for specific patient populations. And some examples of that are, say, with knee replacement. If you break down the data in terms of age cohorts, you can see that young people have, in the green line, have a significantly higher rate of revision risk than old people. And it gives you very sensible information which you can share with your patient regarding their risk of further surgery in the course of their life, should they require a joint replacement. Another very useful output is when we look at BMI, and you can see that the revision risks go up the heavier you are, providing very solid support for the recommendation to lose weight as a key means of reducing risk in joint replacement surgery. So it helps inform patients and surgeons. Onto the surgeons. Well, you can dial into the registry and get into your portal, should you be a participating surgeon, and you can look at your results, and you can see all of the other surgeons, and you can see yourself. And this surgeon here, it's a dummy surgeon in this one, is doing very well in comparison to all of the other surgeons in terms of revision risk for his hip replacements. And you can see yourself, we give data in feedback in terms of funnel plots. You can see where you sit in terms of all of the other joint replacement surgeons around the country in terms of your reoperation risk for any reason. And ideally, you want to be close to the green line or below it, and you certainly don't want to be above the red line. And those people who are above the red line have reason for reflection. We break the data down in terms of other reasons for revision surgery, and in this example, you can see a very low risk for dislocation for this particular surgeon, but a higher risk for periprosthetic fracture for this particular surgeon. And you can look at why you may see more of your patients revised for a particular reason. And taking that example of periprosthetic fracture, The reason for that in this situation is that that surgeon had a particular predilection for using a very stiff device, which unfortunately has a higher risk of periprosthetic fracture, requiring further fixation and revision surgery. What we've identified is the influence of device and surgeon. And if we look at stratifying our data with respect to device usage, you can see, okay, across the board, excluding the 10 best performing prostheses, you can see a lot of surgeons are outliers in terms of revision risk. If you reanalyze that and say, okay, well, we'll just analyze the surgeons that use the 10 best prostheses, very few are outliers. And this provides us with a tool to modify practice and for surgeons to reflect and change. So, does feedback change practice? We would say absolutely yes. Just as an example, taking a surgeon who looks at his or her, I should say, knee replacement survivorship data and says, listen, I'm not quite doing as well as the rest of the world. My green line is above the blue line. Okay, I change. So prosthesis change and technique change matters. And you can measure that change over time. And this is just an example of the before and after change which occurs if you make the right choice. So a lot of these feedback loops have impacted over time. So, for example, unicompartmental knee replacement. Back in the early 2000s, there was a huge vogue for unicompartmental knee replacement. David Murray from Oxford came out and gave a very persuasive talk that everyone should have a unicompartmental replacement, and the usage went up to almost 20% of all patients having knee surgery, knee replacement type surgery. However, because of registry feedback, that has really now fallen quite significantly. And that's really been driven by the somewhat higher risk of revision with unicompartmental replacement over time compared to total replacement. So we're much more selective. Exchangeable neck or modular neck type prostheses in hip replacement also went through a bit of a vogue about 10 years ago, simply because they were more amenable to being inserted through minimally invasive type surgery. However, a higher rate of revision, the green line over the blue line, has really impacted our surgeons' thoughts about these prostheses, and so their usage has plummeted over time. Similarly, resurfacing hip replacement. There was a large move to resurfacings in the early 2000s, and the registry data has significantly impacted the usage of resurfacing hip replacement, which is now almost purely confined to the sort of younger male age group, bringing it back to from about 10% to 1% of all hip replacements. And you can see these just in graphical terms, the impact that registry data has had on prosthesis usage. Okay, you may well ask, is it foolproof? Well, sadly not. And just an example of that is when we consider the use of cemented hip replacements, particularly the cemented stems in patients over 75. And okay, most patients requiring joint replacements are actually in their 70s and over. And if you look at outcomes by age, the cemented hip replacements are the green line with the lowest risk of revision surgery on the graph. Cementless hip replacements are the blue line, significantly the highest risk of revision surgery. And that goes for trauma cases as well, not just people being treated for osteoarthritis. If anything, the difference is even greater in trauma cases where the green line for cemented hip replacements has a much lower risk of revision surgery than the blue line of the cementless. So, sadly, we have been unable to convince many surgeons in Australia that they should be using more cement in their hip replacements, and that remains work in progress. So, sure, it works a lot of the time, but it may not work all of the time. Okay. So, in conclusion, my view is that big data works, but only if you listen to it. It's gratifying that our big data program has really been behind improvements in hip and knee replacement outcomes over the last, 20 years in Australia. And it really has been the major driver behind that. And lastly, just to emphasise the success of this whole process, the burden in our society for revision joint replacement procedures has dramatically reduced over the last 20 years. Hip replacements, it's dropped by about a third, and knee replacements similar. And that rate is progressively reducing over time. And revision surgery is horrendously expensive for both, or expensive for the patient, tiresome for the surgeon, and enormously dollar expensive for the health system. So listen to the big data is the take-home message. So thank you very much.
Thank you very much, Professor. That was fabulous. It was very interesting to see that such a registry exists. And I guess it's not only fabulous in terms of being able to self-audit your own practice and look at what prostheses are available, but I was wondering, does it trigger an audit if there is a surgeon in one of those outlier groups where their numbers are somewhat questionable? Does the registry then trigger an audit of that practitioner or prostheses, or how does that work?
No. So in Australia, we have very prescriptive privacy legislation. And so a surgeon and a patient are completely anonymised. So we know there are outlier surgeons, but we don't know who they are.
Right.
Okay. All right. We'd love to be able to trigger a reflective moment with someone who was a horrendous outlier, but we're unable to identify them. It's completely anonymised. So our registry stands somewhat alone in that. Other registries around the world have different approaches. The Scottish Joint Registry does not have that prescription. And so a friendly chap from the Scottish Registry may invite you to have a cup of coffee one day to reflect on your results. And that is extraordinarily effective. They have analysed their data regarding the sort of coffee intervention and shown that to be massively impactful. The UK, or should I say the English Registry, is not owned by the British Orthopaedic Association, and they have no anonymity, and it's the most hated thing in the world in England, because if someone has, for whatever reason, higher revision risk, and it may be that they're the person that does all the horrible surgery around the place, they get a please explain moment from the Ministry of Health, and a very unfriendly process. So in Australia, the privacy legislation is prescriptive, and as I say, that's been tested now in the High Court, that anonymity is actually very heavily protected by our privacy and our quality assurance legislation. To combat that, I guess not combat it, but to compensate for that, what we do is we advertise and communicate very effectively within the association. So everyone's aware that there's a scatter plot, okay? All right. The guys who are outside the red line are actually changing.
Okay.
The guys, I mean guys and gals outside the red line. So yeah.
does go on. And in the UK, you mentioned, is it mandatory there to be part of the registry?
Yes, it's a government, so it's a health ministry process,
Yeah.
and it's mandatory that your results are all part of the registry there. Yeah,
Okay.
yeah. It's become a bit like Switzerland, the UK. What's not forbidden is compulsory.
Okay, excellent. Well, thank you very much. I'll just see if there's any questions on the chat. Just bring it up here. Here we go. Can the data be used as setting the gold standard of care, for example, with the cement? If a surgeon varies from use on their registry, does that have implications?
No, it doesn't. No, we are not the judge or the jury. We just provide the information. What we do, however, is we do provide guideline level type feedback. So within that sort of guideline process, it comes down to, okay, are devices performing adequately? And similar to the UK system, which is the ODEP system of, if you've got a fabulous prosthesis which is performing brilliantly for 10 years, they get a 10 gold star rating. Okay, we have a similar level of prosthesis rating. Sadly, we can't put surgeon gold star rating in as well.
Yeah. I guess that there's also the problem of the time from initial prosthetic implantation to revision is a significant period, and then you're seeing these outcome measures 10, 15 years down the line, and by that time you've then got another 10, 15-year gap to change your practice whilst the next gaps are coming through. So I guess that has challenges as well for your profession.
It does. Well, you know, we're in it for the long haul. And it is a window on old technology as well. It does tell you what worked well back 20 years ago. Yeah. However, if you look at devices which perform poorly, they perform poorly right from the get-go. It's very rare for something to perform suboptimally and then come back to the pack. I think there are only 2 examples in the whole registry. So if it's going to go bad, it'll go bad pretty early, and you'll know within 3 or 4 years. You won't know within 1 or 2 years because the numbers aren't significant enough.
Right. Okay. So your informed practice change comes about fairly early.
It can do, yes. Yeah.
And one further question: what is the rate of participation among surgeons in Australia in the registry?
Yeah, it's actually 100%. 100% of all joint replacement surgeons contribute to the registry. So it's and completely voluntary.
That's amazing. Are there any other models across other specialties that you're aware of?
I think vascular surgery has a very good national registry. You know, we all live in our silos, so I don't know all about the vascular registry. Certainly, I think there's a renal disease registry as well. Again, you know, there's only so much time in one's life. You can't do more than one registry.
Dr. Bandy said neurosurgery has a decade-old ventricular peritoneal shunt registry. And I think ENT, we have our cochlear implant registry as well. So, yeah. But certainly not as extensive as the orthopedic. Excellent. Well, I think that's all the questions. So I believe it's time for a break. Thank you very much, Professor, for presenting. It was very insightful.